Polycystic ovary syndrome, commonly known as PCOS or PCOD, is a common endocrine and metabolic disorder affecting women of reproductive age. The term polycystic refers to the presence of multiple small cyst-like structures in the ovary. However, it is important to understand that these are not true pathological cysts. It is estimated to affect approximately 6 to 10% of women of reproductive age, making it one of the most common endocrine disorders in this group. Regarding the cause of this condition, PCOS does not have a single identifiable cause. Instead, it is a multifactorial condition in which genetic predisposition, insulin resistance, and neuroendocrine dysfunction all interact with each other. Before we jump into the pathophysiology of PCOS, let's simplify it first. PCOS is not just an ovarian disease. It is actually a problem of communication between three major systems in the body: the brain, the ovary, and metabolism, especially the insulin metabolism. Under normal conditions, these systems work in a coordinated manner to regulate hormone production and ovulation. However, in PCOS, this coordination is lost, and instead of helping each other, they start worsening each other's dysfunction. Now let's understand how this happens step by step. Normally, when we eat, our blood glucose level rises, and in response, the pancreas releases insulin. This insulin goes to tissues like muscle and fat and helps this glucose to enter the cells. As a result, blood sugar levels come down. Now the question is, how does insulin do this? When insulin binds normally to its receptors on the cell surface, it triggers a cascade of signals inside the cell. This involves activation of proteins like IRS, that is, insulin receptor substrate. Insulin activates this protein by adding phosphate groups specifically to tyrosine residues of IRS. This step is called tyrosine phosphorylation. It then activates the series of downstream pathway and leads to movement of GLUT4 transporters to the cell surface. And as a result, glucose enters the cell smoothly. And this happens normally. Now in PCOS, the beginning is still normal. That is, insulin binds to its receptor without any issue. But inside the cell, the signal gets distorted. Instead of proper tyrosine phosphorylation, there is increased serine phosphorylation of IRS. And this is actually a problematic modification. It doesn't help the signal. Instead, it interferes with signal conduction. In fact, serine phosphorylation can block or reduce tyrosine phosphorylation or make IRS less effective. So even though insulin has given the command, the cell does not respond properly. GLUT4 does not move efficiently to the cell surface, and glucose cannot enter effectively into muscle cells. This process is what we call insulin resistance. So in insulin resistance, the problem is not that insulin is absent. Rather, the body's cells do not respond properly to it. As a result, glucose does not enter efficiently. Because the body senses that glucose is still high in the blood, it assumes insulin is insufficient. So it produces more insulin. That is how hyperinsulinemia develops in PCOS. A very important point that most students misunderstand is that in PCOS, obesity can aggravate insulin resistance, but it is not the root cause in every patient. Even lean women can have intrinsic insulin resistance. And importantly, this resistance itself can promote fat accumulation. So both conditions can worsen each other in a vicious cycle. One more point to keep in mind is that insulin resistance in PCOS is selective, meaning some organs remain sensitive to insulin while others become resistant. For example, skeletal muscle become resistant. So glucose uptake is reduced when insulin binds to its receptor. But other tissues like the liver, adipose tissue, and especially the ovary remain relatively sensitive to insulin. So even though the body is resistant, insulin is still able to act on these tissues, particularly the ovaries. So this high chronic insulin level has multiple effects on different organs. Let us discuss one by one, starting with liver. When insulin levels are high, the liver first responds by reducing glucose output through inhibition of gluconeogenesis and glycogenolysis. Under normal physiology, insulin plays a role in controlling blood glucose levels by acting on the liver. When insulin levels are high, it suppresses hepatic glucose production by inhibiting gluconeogenesis and glycogenolysis. In contrast, during fasting, insulin levels fall. This suppression is lifted, and the liver begins to produce glucose through gluconeogenesis and glycogenolysis to maintain adequate blood glucose levels. So high insulin essentially switches off glucose production. At the same time, high insulin promotes excessive glucose uptake in the hepatocyte, and this excess glucose initially converted into glycogen for storage by the glycogenesis pathway. But the liver has a limited capacity to store this glycogen. Once these glycogen stores are filled, then this extra glucose has to go somewhere. At this point, liver shifts its metabolism toward lipogenesis, that is, toward fat synthesis. So this excess glucose is converted into pyruvate, then into acetyl-CoA, and instead of entering the TCA cycle, it is diverted into fatty acid synthesis. And these fatty acids are then converted into triglycerides. Small amount of this triglyceride stored in the liver, and majority of it packaged into VLDL and released into the bloodstream. Now coming to adipose tissue. Insulin has two very important actions there. One, promotes fat entry, and other, prevent fat exit. First, when insulin levels are high, more glucose enters adipocytes and is converted into glycerol, which forms the backbone for triglyceride synthesis. At the same time, these VLDL, which are synthesized by the liver and released into the circulation, when these VLDL reach the capillaries of adipose tissue, they are acted upon by the enzyme lipoprotein lipase, which break down the triglyceride into free fatty acids. These free fatty acids then enter the adipocytes. Inside the adipocytes, the incoming fatty acids combine with glycerol to form triglyceride, which are then stored as fat. And secondly, insulin blocks this fat breakdown. It inhibits an enzyme called hormone-sensitive lipase inside the adipocytes, which is responsible for breaking stored triglycerides into free fatty acids. So when insulin is high, lipolysis is suppressed. Fat cannot leave the adipose tissues. So high level of insulin drives triglyceride formation in the liver and also promotes fat storage in adipose tissue by increasing fatty acid uptake and inhibiting lipolysis. After liver and adipocytes, let's discuss what happens in ovary. Normally, follicular development follows the two-cell, two-hormone mechanism. During the follicular development in the ovary, once the follicle reaches the secondary stage, it differentiates into two cell types that surround the oocyte, the outer theca cells and inner granulosa cells. This is where the two-cell, two-hormone mechanism begins. Now these two cells have different sensitivities to hormones. The theca cells are more sensitive to LH. When LH binds to receptors on the theca cells, it triggers a series of intracellular steps that lead to the production of androgen. These androgens then diffuse into the nearby granulosa cells. Granulosa cells, in contrast, are more responsive to FSH. Under FSH stimulation, they express the enzyme aromatase, which convert these androgen into estrogen. And this estrogen promotes further growth and maturation of the follicle, stimulate proliferation of endometrium, preparing the uterus for possible implantation. Normally, insulin in this setting plays only a supportive role and mildly supports steroidogenesis. However, in PCOS, when insulin levels are chronically elevated, this balance is disrupted. Excess insulin directly stimulates theca cells and also increases their sensitivity to LH, leading to excess production of androgens. At the same time, high insulin and androgen levels impair granulosa cell function, particularly reducing the aromatase activity. So androgens are not efficiently converted into estrogen. As a result, androgens accumulate within the ovary. Estrogen production becomes inadequate for proper follicle maturation, and therefore, follicle fails to develop into a dominant one. This leads to follicular arrest and anovulation. Additionally, insulin reduces the production of sex hormone binding globulin from the liver. Sex hormone binding globulin are proteins produced by the liver that binds to sex hormones, mainly testosterone and estrogen in the blood. By binding these hormones, it reduces the amount of free or active hormone available to act on tissues. So when insulin lowers these sex globulin, more free and active androgen circulate in the blood. At the ovarian level, high androgen directly impair granulosa cell function and further reduces the aromatase activity. So androgen are not properly converted into estrogen. This leads to further poor follicle development and failure of ovulation. As we know, normally after ovulation, the residual follicle form the corpus luteum, which secretes progesterone. This progesterone plays an important role in regulating the hypothalamic pituitary ovarian axis by exerting the negative feedback on the hypothalamus, slowing down GnRH release and thereby reducing LH and FSH secretion after ovulation. Progesterone also helps prepare and maintain the endometrium for possible implantation. However, in the PCOS, due to insulin excess and androgen imbalance, ovulation doesn't occur. So corpus luteum is not formed and progesterone is not produced. As a result, this negative feedback is lost, leading to persistently rapid GnRH pulses. Since GnRH is released in a pulsatile manner, faster pulses preferentially stimulate the pituitary to secrete more LH than FSH, resulting in an increased LH to FSH ratio. Normally, the hypothalamus doesn't release GnRH continuously, rather releases it in pulses. Think of it like drops of water coming from the tap that is not a continuous stream but intermittent bursts. And interestingly, speed of these pulses actually decides what the pituitary will produce. When pulses are slow, the pituitary tends to release more FSH. But when the pulses become faster, LH secretion becomes dominant. So there is increased LH to FSH ratio. The elevated LH then again stimulate theca cells, leading to more androgen production. Those excess androgen impair follicular development and prevent ovulation, which further maintains low progesterone levels. Remove the negative feedback and keep GnRH pulses rapid, thereby creating a self-perpetuating cycle. In a normal menstrual cycle, multiple follicles start developing in the ovary under the influence of FSH. However, in PCOS, due to low or relative insufficient FSH and high androgen levels, many follicles start developing but fail to mature fully. They get stuck in an intermediate state called follicular arrest. Now, these immature follicles do not disappear immediately. Instead, they accumulate in the ovary, especially near the periphery. Over time, they appear as multiple small fluid-filled structures on imaging. These are not true pathological cysts, but rather arrested immature follicles. That is why this condition is called polycystic ovarian syndrome. And this is the pathophysiology. When students first learn PCOS, one of the biggest misconceptions is that it is purely an ovarian disorder. But in reality, as we have discussed, PCOS is a systemic condition involving metabolism, the brain, and the ovary. And focusing only on the ovary leads to an incomplete understanding. Many also assume that androgen excess only causes cosmetic issues like acne or hirsutism. But in reality, androgens play a central role in disrupting follicular development and ovulation, making them a key driver of the disease. Another important misunderstanding is related to the hypothalamic pituitary ovarian axis. Students often think the problem starts at the pituitary or hypothalamus. But in PCOS, the disturbance is more of a secondary dysregulation due to chronic anovulation and low progesterone, rather than a primary defect. Lastly, many believe that all patients with PCOS will have obesity, irregular cycles, and cysts together. But PCOS is actually a spectrum disorder, and patients can present in different ways. Now that we understand the pathophysiology of PCOS, now the clinical features become much easier to interpret because they directly reflect the underlying hormonal and metabolic disturbances. The most prominent feature is menstrual irregularities, such as oligomenorrhea or amenorrhea, which occurs due to chronic anovulation resulting from follicular arrest and hormonal imbalance. According to recent guidelines, abnormal cycles are defined based on time since menarche. In the first 1 to 2 years after menarche, irregular periods are normal because the hormonal axis is still maturing. But if menstrual cycles remain irregular beyond 2 to 3 years after menarche, then it is no longer considered normal and should raise suspicion for conditions like PCOS. Infertility is also common as a result of failure of ovulation. Along with this, patients often present with features of hyperandrogenism, including hirsutism, acne, and sometimes androgenic alopecia. Acne that is severe, persistent, or resistant to treatment, especially in adolescents and young women, should raise suspicion of underlying hyperandrogenism. Hair loss may present in a vertex, crown, or in diffuse pattern. It is important to note that true virilization means development of male-type physical features in female due to very high androgen levels, such as deepening of voice, clitoromegaly, or marked increase in muscle mass, are not typical of PCOS and should raise suspicion of an androgen-secreting tumor. From a metabolic standpoint, many patients may have obesity, particularly central obesity, along with features of insulin resistance, such as acanthosis nigricans, and some patients also experience skin tags. And now, the complications reproductively. Chronic anovulation leads to infertility. So, in PCOS, irregular ovulation make it hard to get conceive. And even if pregnancy happens, the chances of miscarriage and complications are higher, particularly in obese patients. In PCOS, progesterone is not produced. So, unopposed estrogen acts continuously on the uterus, increasing the risk of endometrial hyperplasia and cancer. And abnormal bleeding becomes an important warning sign. Insulin resistance predisposes the patients to type 2 DM, dyslipidemia, and metabolic syndrome, which together increase the risk of cardiovascular disease. These patients also have a higher risk of fatty liver disease and conditions like obstructive sleep apnea, especially in obese. PCOS is also associated with higher prevalence of depression and anxiety, reflecting both hormonal imbalance and the chronic nature of the condition. And now, diagnosis. PCOS can be diagnosed if any 2 out of 3 features are present, namely hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. Hyperandrogenism may be clinical, such as hirsutism, acne, or hair loss, or biochemical, demonstrated by elevated androgen levels like testosterone. Ovulatory dysfunction is usually identified from a history of irregular menstrual cycles, although in some cases it may require confirmation with serum progesterone levels. Polycystic ovaries can be identified on ultrasound. Importantly, if a patient already has irregular cycles and hyperandrogenism, then imaging is not required for diagnosis. Since PCOS is a diagnosis of exclusion, other conditions such as thyroid disorders, hyperprolactinemia, and congenital adrenal hyperplasia must always be ruled out. Thus, diagnosis essentially mirrors the disease process. Now, the management of PCOS is mainly focused on correcting the underlying metabolic and hormonal disturbances. The most important and first-line treatment for all patients is lifestyle modification, including weight loss, diet, and exercise, as even a small weight reduction can improve insulin resistance, restore ovulation, and improve fertility. For menstrual irregularities and symptoms of androgen excess, such as hirsutism and acne, combined oral contraceptive pills are the first-line pharmacological treatment. These can be given as oral pills, patches, or vaginal rings. The progestin component suppresses LH secretion and thereby decreases androgen production. At the same time, these contraceptives increase the level of sex hormone binding globulin from the liver, which reduces the amount of free active androgen in the blood. Some progestins also have a direct anti-androgenic effect. When starting a low-dose preparation containing about 20 micrograms of ethinyl estradiol is recommended, combined with a progestin that has anti-androgenic effects, such as desogestrel or drospirenone. In patients who do not respond adequately, anti-androgen drugs such as spironolactone can be added, as they further block the effects of androgens at the tissue level. However, they are usually introduced only after several months of contraceptive therapy and must be used with reliable contraception due to their teratogenic potential. Since insulin resistance plays a central role, metformin is commonly used to improve insulin sensitivity, help with weight control, and restore menstrual regularity. Metformin alone or OCP alone may be less effective in improving hirsutism than when metformin is combined with OCP. Metformin can be used for menstrual irregularities in patients with a contraindication for hormonal contraception. When managing infertility in PCOS, the first-line treatment is letrozole, which stimulates ovulation and improves the chances of pregnancy. In some cases, clomiphene citrate combination with metformin may be used, especially in women with insulin resistance. Hirsutism, acne, and hair loss, these require long-term treatment, and patients should be informed that improvement takes several months. Newer options like GLP-1 agonist can be considered in obese patients to improve weight and metabolic profile.